everyone. Welcome to Farmland. My name is Tom Davies. My co-host is Bradley Nelson. We're presented by Farm to Table, an educational program from RX Benefits. Looking forward to a conversation. How are you, Bradley?
Hey, doing great, Tom. Good to see you, buddy. And the reason why we're wanting to do this is mainly because we want to provide educational content to you so you know what other things are out there dealing with pharmacy. Typically, when I think of pharmacy, I think of just going to the pharmacy counter. But it's just more than that. There's so many things behind the scenes that you don't necessarily know about, whether it's an industry, a manufacturer, regulations, legislations. There's so many things out there that the general public and even people that are industry insiders just don't know. And so I think with that being said, we want to talk about who we are. So I'm Bradley Nelson. I work for RX Benefits as a Senior Director of Clinical Services. My background is primarily in retail pharmacy, so I've been there, done that, seen a lot of things associated with patients, but I've also worked in some hospital outpatient pharmacies and have learned a lot about that transition of care from inpatient to outpatient and working with things such as 340B. You might not know about it now, but we'll probably talk about it later at some point in time. But my final stay has been at RX Benefits, where I learned a lot and have absolutely enjoyed my time becoming a pharmacy benefits specialist with RX Benefits. So, Tom, why don't you give the audience a little bit more information about who you are and why you're passionate about pharmacy benefits or just industry on pharmacy as a whole?
Appreciate it, Bradley. A little bit of background on me. My name is Tom Davies. I'm a pharmacist by training. I've been with RX Benefits for a little over 2 years now. I am currently the Senior Director of Clinical Products. Prior to joining RX Benefits, I was the Director for a health plan here in the lovely state of Utah, where I call home. Had some additional experience in academia. I've had the opportunity to teach pharmacy students and then manage a health plan with regards to the utilization of particular medications. Why I'm passionate about having these discussions is to help the general layperson understand more about their benefits and hopefully answer some of the questions that have remained elusive in this environment of pharmacy management for the longest time.
Thanks, Tom. Well, let's go ahead and dive into our very first topic for our very first podcast. And it's an extremely timely topic. We're going to be talking about the sensation that is gripping the nation. That is what is called GLP-1s. If you haven't heard it, you must not be following social media or picking up a TV or listening to radio or other podcasts. Everybody's talking about it these days. We've actually got a really good guest for us so that she can bring insights in terms of GLPs and really looking at the GLPs used for weight loss, whether it's off-label or from a label indication. So the question I want everybody to think about, and we'll get to it toward the end as we start answering questions that you might have, is why is weight loss achievement the holy grail of drug development? Well, this is a pretty weighty topic, so we're going to turn it over to Dr. Langley Kyle, who I would like to introduce yourself, Langley, before we ask you some questions to get our podcast started.
Great. Thanks so much, Bradley and Tom. Certainly a pleasure to be here having this chat with you all today. As Bradley introduced, my name is Langley Kyle. I am a pharmacist by training as well. Been with RX Benefits for a little over 5 years and have previous experience in retail as well. So certainly looking at it from both sides of the spectrum, from the patient at the pharmacy counter, but also from the behind the scenes here at RX Benefits from the benefits perspective as well.
Awesome. Well, Langley, I'm going to let Tom toss up our first question to get us started.
So topic one, or question one, is what are these meds?
You know, these medications aren't new. They're new to hearing about it on social media, but they've been around for quite some time. And primarily, they've been utilized to treat diabetes. So you really kind of have to break it into two categories where you have a same chemical ingredient that is approved to treat diabetes on one hand, but then also you have a segment of them that are approved to treat weight management. And that's really important to keep in mind because that's the weight loss component of it is really where you're seeing the hype, really where you're seeing them plastered all over social media, and really where we're seeing the increased popularity of them. They're not a new medication, but we have had some recent approvals for these medications for the management of weight loss. We have seen them come through in social media, really advertising their efficacy, and quite honestly, they've been quite effective at managing diabetes, but quite effective at showing that initial weight loss, suppressing that appetite. And that's really where it all comes from, that feeling of fullness, suppressing that appetite, that ultimately leads to the weight loss down the road.
So Langley, you just mentioned it kind of suppresses your appetite, things of that nature. Isn't there other things that can be used instead of a medication? Diet, exercise. I mean, are there things that could have been used instead of going to these medications?
I think that's an absolutely valid point. Diet and exercise, are key component in when we're talking about weight management and when we're talking about fighting obesity. But I think that as we've seen over time, we've seen the perception of what obesity is being just, I was reading something that titled it as character flaws, like being obese is a character flaw. But really what we are seeing is there are some changes in metabolism that are making it more difficult for individuals to lose weight, to where that diet and exercise is not enough on its own. And so supplementing with a medication like the GLP-1 class has proven very beneficial. I would caveat that to say, though, is, we are seeing real, good outcomes from a weight loss perspective with these medications. But all of the studies that are showing this weight loss are being done in conjunction with diet and exercise. And I think that's a key point to remember, because I think oftentimes that as a society, we're looking for that quick fix. We're working for something that will give us, get us spring break ready, right? But it's really more than that, and it really needs to be handled from a more holistic standpoint of not just drug therapy, but overall management from a diet and exercise as well.
I think that's a really important call out when we talk about the drivers behind obesity. Historically, there was a thought that obesity was simply driven by eating more, exercising less. I think that there's been a really shift within the clinical evaluation of obesity. And since 2013, the American Medical Association has labeled obesity as a chronic disease, with factors contribute to obesity that do include sedentary lifestyle, food intake, lack of physical activity, but there's also a link to genetics that's extraordinarily important as we look to evaluate these medications as a potential treatment for patients that have tried the diet and exercise, have tried the behavioral modifications, but it simply is not working for them.
And I appreciate you mentioning that, Tom and Langley. One of the things that I always find interesting is we always talk about treatment. We always label something as a disease or an illness. And as both of y'all have alluded to, there's an environmental component, right? Sedentary lifestyle, things of that nature, genetics play into this. But going back in time, it seems like this was not necessarily an issue 40, 50, 60 years ago in terms of the actual percentage of the population. And it's not just the United States, right? The obesity rate's 40% in America, but in Europe, in industrialized countries, it's in the 30+% for those, and it's getting worse. So it makes you wonder, what is different now than just really one generation removed, right? Maybe two generations removed. Well, Langley, Tom, what do you think about that?
And first of all, because I'm a pharmacist, I like to put numbers behind increases, right? So if we just look at the obesity, the population within the U.S. that would qualify as being obese, which is a BMI greater than 30. In the 1970s, we were about 15%. We saw an uptick in the 1980s into the 1990s at about 23%. As of 2000, we were at 31%. Per the most recent update, we are close to 43% of the population would now be labeled as obese. So we've definitely seen an uptick in the number of obese patients. But if we take that percentage and apply it to the population, that's about 142 million Americans are now classified as obese. And there's a lot of drivers with regards to changes in lifestyle, access to different types of sugary foods may be a driver. And then there is, like I said, the genetic component that may be driving that change as well.
So, Langley, it sounds like from what Tom mentioned, this is multifactorial, right? It's not something that you can only solve with an injection or a pill or whatever. So what say you?
I say that I could get on a soapbox on a whole nother podcast altogether on all the factors that got us where we are today, and how to get ourselves out of it, right? Because I do think when we talk about obesity, when we talk about really treating any disease state, what's the underlying factor that leads to that? Because that's really where you need to get to. Because once you start introducing drug therapy, you introduce the likelihood of causing another issue, another side effect. And so that's really the things that you have to consider, and why you really can't look at this as, only looking at it from a pharmaceutical therapy. You really have to look at it from, going into some of those other factors that have contributed to it, outside of DNA and genetics, because, to date, we can't change our DNA genetics. That's going to prevent us from being obese. But there are other factors that we can do that. But you really do have to consider, while this is getting a lot of publicity, I mentioned that the medication has been on the market for quite some time. But with its gaining popularity, you're increasing the number of people who are taking these particular medications. And when you open it up to that much of the population, now you start to see some of the side effects that maybe you didn't see when it was used on a smaller scale. And some of those side effects, can be quite significant.
And we'll probably have another podcast episode just specifically on how the consumer and what the impact would be for them, whether it's positive or negative associated with weight loss. But I did want to ask this question. What is we're going back to our original premise of off-label use or label use, GLPs and things of that nature. I want to kind of bring us back just a second to really talk about how did we get to that point where a manufacturer makes the same thing, labels it one thing for one indication, labels it another thing for another indication. Why is that happening? Is there a motivation there to do that? Why not just call it Ozempic and that's it? And Tom, you can jump in too as well, man.
I think that's a great point. And really where you see this is how plans cover medication. We mentioned about a change in perspective of what obesity is to where it was, lifestyle choices versus, being labeled as a disease state. And I really think you have to look at what you've seen in terms of coverage for this. I think it was back in the 90s where Medicare or Medicaid came out and said, these are class of medications that we don't have to cover. And Medicare followed suit. And so you do see a lot of pharmacy plans that don't cover medications for weight loss, but quite clearly they are going to cover medications for diabetes, because diabetes has always been really viewed as a chronic disease state where weight loss has really had that different perception. And so by doing that, you've created these two classes of medications where they have the same ingredient, but you have one that's going to be for diabetes that will be covered on insurance plans, and one that's for weight loss that may or may not be covered on health plans. That's where you get the off-label use and the system workarounds. Because if you have a plan whose intent was not to cover weight loss medications, these medications can be used off-label for diabetes. And without appropriate management of those, you could see them coming onto the plan, really circumventing what that plan intent is.
I really appreciate the insight, Langley, and you really touched off on a majority of the differentiators there. The only call out that I would make with regards to that, well, oftentimes we're seeing when it comes to these newly approved GLP-1s that have either an indication for the management of type 2 diabetes or indicating it for the management of weight loss. There is some differentiation with regards to the dose associated with these drugs. The utilization of semaglutide, which is both approved for type 2 and weight management, is slightly higher in the weight management dose. Secondary to that, the manufacturers have upped the price associated with that. So there is some differentiation associated with the doses of these medications. With that being said, if you don't have access to the higher dose drug, what we are seeing within the marketplace is the off-label utilization of the lower dosed medication that is indicated for type 2 diabetes, just secondary to lack of access for the drugs indicated for weight management.
Good point, Tom. And I think we're going to take a little brief pause because we've had some discussion back and forth and kind of talk a little bit about news of the weird. You know, it's kind of like, let's have a little bit of a break because we're going to switch over to a little bit more of a parallel topic with this, companion topic. So, Langley, Tom, have you heard anything lately? Any cool stories? I got one in case you need it, but I want to check with y'all. Any cool stories y'all might have?
Bradley, I'm going to lean on you with regards to cool stories.
Yeah, you know, well, as pharmacists, or we got 3 pharmacists on this call, and whenever we get 3 pharmacists in the room, that could be as good as 1 Ambien, right? So we want to make sure that we wake y'all up, talk a little bit about something that's out there, get your mental acumen going. And so I got a little news story that I wanted to share with y'all. So, Tom, dog or cat fan?
Cats, all the way.
Oh, man. Langley, dog or cat fan?
I mean, neither. We have a bird and a fish, so.
Bird and fish. Apparently, I'm the only dogs fan here. So, well, I guess this is going to cater to me and all those dog lovers out there that will think this is kind of an interesting story. So this comes from across the pond over in the lovely country of Italy, where Italy actually in one province, which is kind of like a state, for them, they actually have put in a particular system of fining people whose dogs in the dog park or any other place might, quote, do their business and not clean up. So what the Italian authorities have decided to do is to start picking it up and testing it using DNA technology to find out which pooch is the problem. And when they find who that pooch is, they decide to actually fine anywhere between 300 to 1,000 euros. That's like $350 to $1,100 in American money, probably a little bit more with exchange rates, fining them to be able to, for littering, as it were. And so it's really interesting to see that what lengths the regulatory agencies will take in order to make sure to keep these dogs in line. I know it's a little bit of an interesting one, but just kind of wake you up on this first podcast day.
This solidifies why I'm a fan of cats.
I was going to say, I think there's a lot of HOA managements that are probably going to tune in to see how effective this is.
You might be right. I can already see the guy down the street walking in front of my house with his clipboard, Langley. So just kind of throw something out there that's lighthearted and fun for us to talk about. We're going to periodically insert some of these news of the weird as we go through our podcast. But we've been on this weighty topic associated with GLP-1s, the craze that's facing the nation, and whether or not you use things off-label or label indication, and that you have different aspects of how one drug can be used in 2 different ways, right? So what's the reason that these drugs really don't have widespread coverage today? Why don't insurers want to pay for these things?
I think that it goes back to perception of what obesity is. But I also think, we talked about the price of these medications, and they are quite pricey. We have had weight loss medications are not new. They've been around for quite some time. What we are seeing is a difference in how they're working. But I think you've also seen in the past, in the 90s, with a drug called fen-phen that had some very significant side effects and was actually removed from the market. You have a risk versus benefit. Is it riskier to take the medication to lose weight versus being obese in and of itself? And things like that have kind of impacted our perception of that and our coverage of that. I mentioned before coverage with Medicare and Medicaid. Oftentimes what you see going on with Medicare and Medicaid will trickle down into your commercial business. And so I think each of those things have really kind of impacted in how plans make decisions about whether or not to cover the medications. But I think now when you're looking at it, yes, you're seeing medications that are quite effective. They are lowering, they are, causing weight loss. There are studies now showing their cardiovascular benefit. But you're also looking at a lot of these benefits that are more of a long-term solution. And there is some thought in an industry where there's high turnover, really investing in medications like that where they may or may not reap the benefits because those individuals may not be with the company for a long term. Individuals aren't staying in companies as like they did, in decades past. You do see that movement, and there are some considerations for coverage for that as well.
So how expensive are we talking about? I've heard a lot of statistics here, and Tom, you're quick on your feet. You've always been that way. When it comes to, I think you mentioned 40%, over 40% is the obesity rate now. For an average employer group that's even considering this, dollars and cents, what's this really looking out to be? And if there's any potential benefit, which we know there is a benefit long term, what does that look like from a dollars and cents as well?
So just from kind of the basic dollars and cents with regards to the cost of these medications used to treat weight loss, they're right around $1,300 per month. So if we look at a group of 1,000 employees, and let's say 40% of those employees may meet this threshold of obesity, that equates to some pretty significant number of patients utilizing said drug or potentially qualifying for said drug. It's about 400, easy math, right? So 400 members times, let's just say $1,200 times 12 months is a little under $6 million.
And for that average employer of 1,000, their entire drug spend is what? A fifth of that?
Yeah.
Normally? So you're basically going to quintuple their spend if everybody were able to get on that?
Yeah, and I think that because there's scarcity with regards to the long-term benefits associated with these medications, and based on the information we currently have today with regards to how long a patient may need to be on drug, all indicators are this is going to be a drug that will need to be used chronically. So this is going to drive costs year over year. This isn't a one and done. In no way do we feel that this is a cure for obesity. We're not there yet, but it is a consideration of a chronic treatment. And plan sponsors just need to be aware of the potential cost associated with the utilization of these drugs. As we work through, ultimately, what does this mean for an overall reduction in healthcare costs? Are we seeing less cardiovascular events? Are we seeing less arthritis associated with this? Are we seeing more less absenteeism and more presenteeism with members utilizing this drug? Those are some of the metrics out there, outcomes out there that we're still evaluating and waiting for more robust data to support that.
Yeah, I think that's an excellent point, talking about how the duration that these will be utilized, because we do have studies that are showing today that when the medication is stopped, a good portion of the weight loss is returning. And even the cardiovascular benefits are going back to what their baseline risk was. So, while we don't have the full picture of all the long-term benefits and the impact it will have on healthcare spend, we do have enough information to, I think, really say that in order to maintain these benefits, that individuals are going to have to continue with the drug.
Okay, so For plan sponsors that don't cover this today, have y'all heard? I mean, I've heard that there's a lot of compounding going on, right? People are trying to access those medications. Are there any other creative ways that patients are trying to get access to these medications outside of the normal course of pharmacy benefits and that we need to talk about?
Yeah, there's a few avenues that people have pursued. One is compounding. You have compounding pharmacies that see an opportunity to provide this. And because there's a shortage of it, they were allowed to do so. Typically when you compound, if it's commercially available, you're not able to compound that. But when there's a shortage of it, it does open that up. But it also opens up, some of the risk and additionally some expense there. And you've also seen people get creative about where they're sourcing it from. International sourcing is something that has been looked at. And while we're having a shortage of that, the drug manufacturers overall are having a difficulty time keeping up with the demand. While I think that we expected this to be popular, I don't think we expected social media to have it take off and with the trajectory that it did. You saw individuals looking to Canada for that, and actually Canada came out and actually kind of prohibited their pharmacies from dispensing them to the U.S. because they've got to preserve those for their individuals, because like we said, we're not just talking about weight loss, we're also talking about diabetes, and it's inhibiting the ability of those people who are managed for diabetes from getting those medications when there's.
And Tom, I see another podcast episode to talk about drugs from Canada. So we're going to talk. We're going to probably have a podcast episode on that. We might actually tag you or call you up, Dr. Kyle, and have that conversation.
Running list of topics.
A running list of topics. So I want to go back to the overall question that we asked at the top of the call. Like, why is weight loss achievement the holy grail of drug development? Really wanted to kind of think about that question and just dwell on it for a second. There's a lot of dollars and cents involved here for somebody. And it sounds like from what you're saying, it's an ongoing treatment. So this is an ongoing revenue stream for those that can make these products. So they can come, and there's a hype around it, right? So, in terms of this, I can see this being a huge windfall for the people that create these items, for these treatment items. So I want to kind of turn things into the grab bag. We do have some questions that were brought up to us on this topic before this. Going forward, we want y'all to be, as our podcast listeners, to send us topics so that our questions so that we can answer them as you're asking them. But I do want to go into a couple of different questions that we didn't necessarily ask each other, because this is not a pre-planned option here. But I did want to ask, in what case are these drugs appropriate? Could you exclude the entire category, or is there a reason why these can be appropriate, or in what way? And that doesn't necessarily have to be indication based. It's GLPs. Should I exclude them, or can I exclude them all, or are they appropriate in every circumstance?
Well, and I do think you do have to look at the two different classifications between diabetes and weight loss, and currently you can exclude those medications for weight loss. You can exclude that entire class. Excluding all of GLP-1s can certainly have some implications down the road, because it is prohibiting some of the access to care, because we do see some health benefits for those. I do see also movement in having those particular medications required for coverage. You have the AMA, or the group of physicians, really petitioning to have more insurers cover weight loss medications, because again, it goes back to viewing obesity now from the terms of it being a chronic disease state, and you're seeing effective therapy, so they really see the benefit in insurers covering it. But you also see, you said, why are we really talking about this? Yes, it's got great health incomes, but it's the financial impact that it's having that's making it the big story from a benefits perspective, right? And you have those drug companies like Novo Nordisk who are now lobbying Congress to include weight loss in coverage of Medicare and Medicaid, or to repeal that decision before that their policy to not cover it. So you're seeing more discussions about this and including it for coverage, and I think that that's going to be a topic that continues to grow. You talked about the different groups that cover versus not cover. I mean, certainly what you see in those that are covering it are going to be those that have high competition of talent, so they really want to offer those benefits. And so as you see that competition, having that offering for individuals can potentially make you as an employer more marketable.
Yeah, and I think when it comes down to electing to cover weight loss as a client, as a plan sponsor, I think that there's a key element that may be getting missed here with regards to not only covering it, but then making sure that you have the necessary surveillance moving forward, that once a member qualifies for drug, is on drug, are they seeing the benefit that we would anticipate? Are they seeing any unusual side effects associated with this drug that we didn't anticipate? So having ongoing surveillance just to ensure the utilization is most appropriate, and we're seeing the benefit that we'd anticipate. Because even within the clinical trials, there's a certain population that were studied within the trials that did not respond to drug. And so just having that ongoing surveillance to ensure patients that are benefiting from drug, they're meeting particular metrics, we move forward with ongoing surveillance and authorizations. But for patients it's not working for, you no longer have to need access to said drug.
Awesome. Well, we're getting to the end of our podcast time, and I think we've only breached the surface on this topic, and we're going to have another episode that kind of expands the discussion on these medications, and really going to ask the question with our next episode of, are these new weight loss meds really worth the hype? Or are these diabetic meds worth the hype? So we're going to be talking about two different things where it might be appropriate in one case, might not be appropriate in another case. And are there really some outcomes that we know now that we can judge on how well these drugs will perform in the future and on? So that will be on our next episode of Farmland, with that title being called OOO Overpromise. Stay tuned for our next podcast. I'm Bradley Nelson, my co-host, Tom Davies. Say bye, Tom.
Bye, guys. Thanks, everyone.
Thank you, Dr. Kyle. We appreciate you.